Good evening, everyone. My name is Sahar Mohammed Hesham, and I am board certified infectious disease clinical pharmacist licensed here at the UAE with a master's degree in the clinical pharmacy. Today, I will discuss one of the most important and frequently asked questions, whether or not I can use cefotaxime as a third generation cephalosporin for my critically ill patient. Also, the principles for the double and pseudomonal coverage to be used for those patients. These are very important to be addressed, especially in the areas where we are implementing antimicrobial stewardship. So I start my presentation with the question itself. This is one of frequently asked question. It has been asked to me many times, and so I try to make a screenshot for the question. But this question is written in Arabic, so I try to put it in English in order to be easier for you to track the question. First, the question is, the doctor, thank you for your help, but I cannot find what I need in the guidelines. Sometimes I see cefotaxis being used and sometimes meropenem with levofloxacin, which is Tavanic. I want a reliable source that tells me whether cefotaxime is correct or not and what the other combination that can be used. I want to know what should be given depending on the source for infection, especially in the cases of sepsis. So, in order to make an organized and logical thinking answer for this question, we need to track some points before I'm trying to answer this question, because this question appears to be simple, but it's very complicated because there is no single uh, answer at the guidelines that tells us to whether or not to use cefotax and whether or not to use double anti-Pseudomonas. So, first of all, I will start with the cefotax and when to use it appropriately. First of all, cefotax is primarily used for the community-acquired infection. For example, for the community-acquired pneumonia, it can be used as a beta-lactam backbone combined with the macrolides and fluoroquinolones as recommended by the IDSA CAP guidelines 2019. In the bacterial meningitis, it has been used for the community-acquired infection in combination with the vancomycin, and take care that the vancomycin here is not used as an anti-MRSA. It's used here for to covering the strep infection. Also, we add the ampicillin for those patients who are at high risk for listeria, like those patients who are elderly, more than 50 years old, immunocompromised, or even pregnant. Our reference at IDSA Bacterial Meningitis Guidelines 2017. Also, it can be used for the spontaneous bacterial peritonitis, where the cefotaxime and the ceftriaxone remain the first line therapy. We usually use 2 gram IV every 8 hours according to the AASLD guidelines. Uh, there are other uses or recommendation for the use for the cefotax in other community-acquired infection like neonatal sepsis, especially the early onset, where the neonates take his infection from his mother, where they use the combination therapy with the ampicillin, cefotaxime, or we can use ampicillin with the aminoglycoside depending on the risk factors and the availability for the agents. This is the reference by the American Academy for Pediatric, Trade Book 2021, and also the NICE guidelines 2021 has been addressed these recommendation. Also, we can use the neonatal gonococcal infection for the as an alternative for the ceftriaxone as a reference by the CDC Sexually Transmitted Disease Guidelines 2021. Also, we can use it for the intra-abdominal infection, but take care not only the intra-abdominal infection are being recommending the use of the cefotaxime as a routine, only the mild to moderate infections where the option we can usually use the cefotaxime in combination with the metronidazole. The reference is IDSA Intra-Abdominal Infection Guidelines 2010. Also, we can use Cefotax appropriately for the complicated urinary tract infection, where there is a very low prevalence for the pathogens such as an ESBL or Pseudomonas, and we can use it for those patients who has not any risk factors for resistance. Okay, so we can use the Cefotax or even the ceftriaxone for the complicated UTI, even in the urosepsis according to the the complicated urinary tract infection IDSA guidelines, the recent updates is 2025. Not effective against Pseudomonas or ESBL, the carbapenem is usually the preferred option for the ESBLs. When should we not use Cefotax? Okay, usually we do not use Cefotax in the hospital-acquired pneumonia or hospital-acquired infection because those nosocomial infection, usually the Pseudomonas is the core pathogen. Also, we did not use the Cefotax, as I mentioned, in the ESBL or in the Acinetobacter, or when the sepsis is being of unknown source, so a broader spectrum empirical therapy can be started. As a take-home message, we usually do not use Cefotax as a prophylaxis at all because this will increase the risk for resistance and it is against the implementation for antimicrobial stewardship. We usually limit the use of Cefotax as a definitive and empirical therapy in those infections that are being community-acquired infections, not nosocomial infections. Okay, so this is regarding the Cefotax. We need to shift now to the use for antipseudomonal. And before I start, I want to make a quick review for those agents that cover Pseudomonas as a start for those who are not knowing which agents are being used as an anti-pseudomonal. We used usually piperacillin tazobactam as a beta-lactam. We usually use cefoperazone, cefadricol, cefepime, and ceftazidime as a cephalosporins. Also, we can use the novel beta-lactam such as ceftriaxone, tazobactam, ceftazidime, avibactam, or fluoroquinolone like Cipro and levofloxacin. Aminoglycosides. Importantly, you should know that the Cefotax and ceftriaxone are not used as an anti-pseudomonal or not being considered as an anti-pseudomonal agent. Also, we can use the carbapenems like the meropenem, doropenem, and imipenem/cilastatin. We suspect Pseudomonas in those with a community with hospital-acquired infections like hospital-acquired pneumonia or ventilator-associated pneumonia. Take care because the Pseudomonas here is a core pathogen. So when we are using to or we are recommending an empirical therapy for those infection, we usually put the Pseudomonas beside our eyes, in front of our eyes, and we usually use the anti-pseudomonal beta-lactam to treat these infections. Okay, so mainly you are focusing on the anti-pseudomonal beta-lactam. You can add on another another Pseudomonas or anti-pseudomonal agent when there is an MDR risk factors. This is according to the VAP and HAP IDSA guidelines 2016. Those who are presenting with community-acquired pneumonia, you should know that the Pseudomonas is not the core pathogen. So we will not use anti-Pseudomonal at all, except if the patient has Pseudomonas risk factor, like previous colonization with the Pseudomonas or the IV antibiotic and recent hospitalization. So we can use an agent that has anti-Pseudomonal bacteria. But as we know that we should not use double anti-Pseudomonal at that situation because the Pseudomonas is not a core pathogen. طب when we can use double antidomonal in this situation, usually we use it when the patient has a previous colonization with Pseudomonas that is multi-drug resistant or not susceptible to the single agent that I will be used for it. So I can use a double antidomonal in order to increase the possibility for eradication. For complicated urinary tract infection, we are not using routine anti-pseudomonal except in the healthcare associated cases where the Pseudomonas is being considered due to the previous colonization for the patient. And this is according to the 2025 IDC guidelines for complicated UTI. Also for the healthcare associated infection like intra-abdominal infections, we should not consider the Pseudomonas at the core, but we usually give anti-Pseudomonas for those agents or for those infections because we usually want to give a broad spectrum. So we use the anti-abdominal beta-lactams not to focus on the Pseudomonas, but we use it because they are the broad spectrum. Okay, and this is a very important point to be addressed. Not all the infection that we use anti-Pseudomonas, we usually focus on the Pseudomonas. No, we are focusing on gram-negative bacteria, and we are usually use them in order to cover a wide range for gram-negative bacteria. Also, for febrile neutropenia, we use single antidomonal. We do not use double, except if the patient is high risk, as I will mention in the next slide. For the skin and soft tissue infection, we usually consider the Pseudomonas in the burn patients or patient with burn wounds, neutropenic patients, or those who have a healthcare associated skin and soft tissue infection and usually colonized with Pseudomonas. For other infection like abscess, cellulitis, endocarditis, and osteomyelitis, Pseudomonas is not a common pathogen. We not usually focus on treating with anti-Pseudomonas or double antidomonals. We usually use to give broad spectrum antibiotics if the patient need this one. But usually in the endocarditis and the osteomyelitis, we usually focus on the pathogen by the culture and usually give targeted therapy because, as you know, those infections are are deep-seated organ infection. We usually use antibiotics for a very long time. So in order to be specific and targeted, you will usually give antibiotic guided by the organism and guided by the culture. This slide is very important. This algorithm is very useful algorithm, have been downloaded from the UpToDate. It's summarizing when we can use combination with double antidomonal and when we can use single antidomonal and when we can use a single agent that has no antidomonal activities like ceftriaxone. These are three situations, and even there is another situation where we can use the one of the newer or novel beta-lactams like beta-lactamines that inhabited like ceftazidime, tazobactam, ceftazidime, and ifeactin. If the patient has extensively drug-resistant organism, usually it's carbapenem-resistant enterobacteriaceae. So, not all the patients that are being presented with sepsis and septic shock should be treated with double antidomonal. Okay, they may be treated with double antidomonal or single antidomonal or even agent that does not have antidomonal activity at all. Okay, it's depending on other factors. Let us go through this algorithm to know what are the risk factors or what are the situations that leading us to use double antidomonal. First of all, if there is a gram-negative loss being suspected from the blood culture and the patient has a sepsis or septic shock, yes. If yes, then we should ask ourselves some question like, is this patient is immunocompromised? If this patient has healthcare exposure in the 3 to 6 months, and I mean healthcare exposure that the patient is on hemodialysis or recent hospitalized or resident in long-term facility or have IV antibiotics or take chemotherapy, okay, or took chemotherapy in the prior 3 to 6 months, or if there is an institutional prevalence for resistant gram-negative is more than 20. And this issue is very important because usually we get this information from the infection control. When the infection control make a prevalence study and calculate the prevalence rates for the resistance. If the resistance or the prevalence for the gram-negative resistance is more than 20%, then you should go for the double antidote. Okay, it's better to use aminoglycoside as a second antidomonal rather than use for fluoroquinolones. And this is a very important issue because the question, as you remember from the first slide or the second slide, I'm mentioning the question is being mentioned that we use meropenem plus fluoroquinolones. If there is a bacteremia or sepsis, it's better to use aminoglycoside. Okay, and it's better to use topramycin, as I mentioned. But if this patient has has a sepsis, okay, but does not has these risk factor, then we can go for the single and pseudomonal, and we should not give this patient double agent. If this patient does not have any sepsis or septic shock, and also this patient does not have any of these risk factors, then you have a very wide range options that you can go through. You can even give pseudomonal beta-lactam, or you can give even an agent like cefotraxone or cefotax, because this patient will not have the eligibility criteria to take the very broad antihormonal beta-lactam. In order also to clarify whose patients are being considered as immunocompromised host or have immunocompromised condition, those patients that have a poorly controlled diabetes, chronic high doses glucocorticoids, or those who are being using immunosuppressant agent, neutropenic patient and advanced IV infection, and those who has B or T leukocyte deficiency. So, to summarize, is the use for double pseudomonal routine for all patients with sepsis? No, they should be taken in sepsis or septic shock where there is a multi-drug resistant Pseudomonas, or there is a multi-prevalence for the gram-negative bacilli resistance more than 20%, or even you have an ICU and you have an antibiogram, animal antibiogram that show that the single pseudomonal that you are using, there is a resistance pattern, or there is a resistant rate from it more than 10%. So you should not use single pseudomonal, you should use double. Or the patient has a prior colonization with multi-drug resistant Pseudomonas, or have a prior colonization with other multi-drug resistant like Acinetobacter, because even you know that the Acinetobacter multi-drug resistance, especially the CRAB, the carbapenem resistant, should be treated with combination therapy. Also, the patient who has are being high risk febrile neutropenia, hemodynamically unstable, or has any immunocompromising condition, okay, then the patient should take piperacillin, tazobactam, cefepime, or venlafaxine plus aminoglycoside. Levofloxacin is only used if there is if the patient does not develop sepsis. The patient has a nosocomial pneumonia, so we can go through the levofloxacin. You even de-escalate once the culture is available and patient is candidate for de-escalation. For conclusion, cefotaxime is a correct for CAP, for community-acquired infection, not appropriate for ESBL, for Pseudomonas, for Acinetobacter. If the patient has any risk factor for these organisms, so cefotax will not work. Antihormonal agents usually use double for only when there is depending on the infection itself, where the Pseudomonas is a core pathogen, or the patient has, and the patient also had multi-drug resistant risk factor. The patient is being colonized with multi-drug resistant Pseudomonas, or there's a high prevalence for multi-drug resistant Pseudomonas or multi-drug resistant bacteria, where if we use only single agent, it will not goes perfect, or will not be an efficient, so you need to use combination. Always the de-escalation, depending on the culture and sensitivity, it's perfect, and it's one of the stewardship recommendation, but don't forget to know to consider the patient condition, because the patient must be a candidate for de-escalation. Finally, thank you for your attention. I will be happy for any of you of any question that is being posted to me on the WhatsApp or on the Facebook or on LinkedIn or in YouTube. Feel free to post to me questions. Thank you for your attention, and see you soon on Friday, inshallah, to discuss if one of the your question, one of the most frequently asked question. Thank you and goodbye.